Good afternoon, everyone, and very warm welcome for today's MedTalk digital session. I am Adaf Sheen, your moderator for this program. Today, we focus on an age old but still puzzling theme in internal medicine: fever of unknown origin, old problem, new approaches despite decades of medical advancement. FUO continues to challenge clinicians with its broad range of possible causes. And this session, we will explore how modern diagnostic strategies and clinical insights are reshaping the way we approach this intriguing condition. It is my honor to introduce our speaker, Dr. Usman Dhruv. He did MBBS, MD Internal in Medicine. He is Director in Internal Medicine and Diabetes at HCG Hospital in Ahmedabad. Dr. Dhruv has an extensive experience in managing complex medical cases with a special focus on internal medicine and diabetes care. His expertise and practical approach make him uniquely positioned to guide us in understanding the evolving strategies for diagnosing and managing FUO. We are truly privileged to learn from his experience today. Dr. Dhruv, sir, we are eager to hear your insights on this important subject, sir. Sir, the stage is yours now.
Thank you. Uh, I I cannot see my presentation. Okay, fine. Ada, thanks a lot for introducing me. As such, Shakespeare has said that what is there in a name, but it occasionally matters to me. It is Urman and not Usman. Good afternoon, everybody. Uh, what we are going to talk in next 30 or 35 minutes is pyrexia of unknown origin. Before we know anything about pyrexia of unknown origin, let's talk something about who was the first person who introduced how to measure fever. And he was none other than the Centurio Centauri, who was an Italian physician who introduced a thermoscope. And then came the Thomas Clifford, who introduced a thermometer about 200 years later. What is fever? Because pyrexia of unknown origin can be talked about only if we know what is pyrexia. So, fever is an elevation of body temperature that exceeds normal daily variation and occurs in conjunction with an increase in hypothalamic set point, suggesting that body temperature is controlled by hypothalamus. So, pyrexia of unknown origin, for that we require a thermometer, for that we require to define pyrexia, and for that we require to define what is normal daily variation. So, what is normal daily variation? Very few of us know these things. Mean oral temperature is, we'll be restricting ourselves to Fahrenheit only, which we are more accustomed to. So, mean oral temperature generally is 98.2 plus or minus zero point 0.7, meaning thereby up to 99 degree Fahrenheit, it is a normal mean oral temperature. It is lowest at 6 a.m. and highest between 4 and 6 p.m. Remember during the time of COVID, we used to get a lot of calls in the evening that I'm having a fever of 99 or 99.2. Well, that is a normal variation. The maximum normal temperature at 6 a.m. is generally 98.9 and at 4 p.m. is 99.9. Look at these ranges. And therefore, any morning temperature more than 98.9 and evening temperature more than 99.9 is known as fever. There would be a difference of zero point 0.4 degrees Celsius or zero point 0.7 degree Fahrenheit between rectal and oral readings. Also, one should remember that a menstruating female will have a lower temperature as compared to those who are not menstruating. So, there are a lot of physiological variation in fever. Coming to the most important topic, and that is patterns of fever. Again, it is like Duryodhan. We know the religion, but we don't know how to apply it. So, what is continuous fever? Remember these four patterns of fever practically help you a lot in differential diagnosis of pyrexia of unknown origin. Continuous fever, where there is fluctuation in temperature of less than 2 degree Fahrenheit and not touching baseline in 24 hours. So a person can have a presentation like this. The temperature pattern is not different, as you can see in the upper graph, by 2 degree Fahrenheit, and it is not touching the normal body temperature. Intermittent, it's a fever with fluctuation of more than 2 degree Fahrenheit, but temperature touches at least once to the baseline, as you can see in the lower graphs. And then comes the remittent fever, where there is high degree of fever with wide fluctuation, more than 2 degree Fahrenheit, and not touching the baseline. And then comes the relapsing fever, period of pyrexia of few days, followed by period of apyrexia. When we talk about the second group of fever, that is intermittent fever, one can classify it into different patterns depending upon when the fever appears in the form of tertian, quaternion, or quaternion. What causes fever? Fever is generally caused by pyrogen. By pyrogen, most of the time we believe that it is some substance. Not necessarily. Anything that causes fever is known as pyrogen. It could be a microbial product, microbial toxin, or whole microorganism itself. For example, when it comes to gram-positive organism, Staph and Streptococci, they are actually themselves superantigens. Staph aureus produces toxins, while gram-negative organisms produce fever because of lipopolysaccharide cover. Let's take an example before we go on to pyrexia of unknown origin. Is this pyrexia of unknown origin? 21-year-old male presents with fever with rigors of 4 days, headache, backache, anorexia, no vomiting, no dysuria. Examination is normal. We go for certain investigation and we get the diagnosis. Well, this is pyrexia but not pyrexia of unknown origin. Another example, 21-year-old female, fever with rigors 4 days, headache, backache, dysuria, vomiting. Normal examination except mild tenderness in right renal angle. Again, we go for certain investigation and we get the diagnosis. The one, as you know, is probably an infective pathology, probably parasitic in origin or viral in origin. The other one is urinary tract infection. Another example, 55-year-old male is brought in unconscious state from railway station. Temperature 106 degree, pulse 136, tachycardia, probably developing hypotension, hot, dry skin, pupils are normal, which rules out probably poisoning or intoxication. Systemic examination is normal. How do we go ahead? We think about differential diagnosis, then we think about which investigations to order one by one, and then we order certain investigation to get the diagnosis. If we don't get the diagnosis with blood investigation, we might have to go for further investigation. But still, this is not pyrexia of unknown origin. So, pyrexia of unknown origin requires us to be conversant with certain common causes of shorter duration, like malaria, viral fever, typhoid fever, respiratory tract infection, viral hepatitis, urinary tract infection, dengue or chikungunya, boils, cellulitis, and abscess, and certain serious disorders which does not come under pyrexia of unknown origin, like complicated malaria or complicated meningitis or complicated encephalitis. So now we go to our topic, pyrexia of unknown origin. After we know what is pyrexia, what are different types of physiological ranges, what are different types of pyrexial patterns, and what are common causes of pyrexia, which we need to exclude before we jump onto a diagnosis of pyrexia of unknown origin. In 1961, it was defined as fever more than 101 degree Fahrenheit for more than 3 weeks, out of which 1 week has to be in a hospital and investigations not revealing the cause of fever. The definition still holds true, but not in its complete entity. There are certain few changes because most of our patients of pyrexia does not require hospitalization of 1 week or more. So there is some change in the definition when it comes to pyrexia of 1 week hospitalization. What do you need when you want to diagnose pyrexia of unknown origin? You require dedication, an active mind, because only what a mind thinks, eyes can see. So if your mind is not thinking well, you cannot diagnose PUO. Always think about differential diagnosis. We have got a very bad habit of jumping to a diagnosis the moment we start hearing the history. Fever with chills and rigors will jump onto malaria and UTI. So when it comes to pyrexia of unknown origin, we have to keep our mind active, open. We should be ready for lot of thinking, and we should think about multiple diagnoses rather than one. But the most important thing that I would suggest a physician to spend time on would be history taking. Unless you spend enough time on history taking, you cannot diagnose a patient having pyrexia of unknown origin. Let's give you an example of a case of recurrent UTI in a female having weight loss. Well, that patient came to us, 4 weeks of pyrexia, recurrent UTI, lots of investigation, having urine culture, lots of antibiotics used, and still she continued to have the symptoms. We gave enough time, we took history, and then we started exploring the investigation. And suddenly we could read only one line. Urine showed fecal material. That gave us a clue. We went to explore further and we realized that that was a case of vesicorectal or rectovesical fistula, which led to recurrent infection. So, an open mind can help you to diagnose pyrexia of unknown origin. Most febrile illnesses in adults either resolve before a diagnosis or develop distinguishing characteristics that lead to a diagnosis. And that's why, in an adult patient in 2025, pyrexia of unknown origin has become little remote as compared to pyrexia of unknown origin in children, which still remains an unresolved mystery. About 5 to 15% of patients having a diagnosis of pyrexia of unknown origin even today remains undiagnosed. Even today remains undiagnosed with the best of evaluation facilities. But the good thing is, longer the duration, more the investigations, chances of a pyrexia of unknown origin being a critical or a serious illness go down. Again, in 1991, Durack and Street classified pyrexia of unknown origin into four different patterns: classic pattern, nosocomial, neutropenic, and HIV related. It had got its own different diagnostic patterns. What was classic PO? Generally, the causes were infections, neoplastic, collagen disease, or miscellaneous. So, the newer classification now put pyrexia of unknown origin under the heads of four different etiological patterns. Remember, these are not diagnoses. These are four different probable etiological patterns, and there would be many more which will be out of all these four different etiologies. Classic commonly include infections, collagen diseases, malignancy, vascular disease, and miscellaneous. Nosocomial includes C. difficile and tracholitis, drug-induced pulmonary embolism, septic thrombophlebitis, and sinusitis. Immune deficient or neutropenic, Previously, it was known as solely neutropenic. Now it has been realized that it is immune deficient or neutropenic. Could be because of fungi or viruses. And then HIV related could be because of different viruses. What are the relative causes in different population? The upper one, that is the gray colored, gray shaded bar, is unknown. And look at the children. Still about 20% of cases are unknown. But when you look at the uh, people more than 65-year-old, that is the second graph, the unknown area is even more gray shadowed, suggesting that it is in the children and people above 65 years of old age where the unknown causes still occupy the most of the pattern. What are the risk factors for pyrexia of unknown origin? Suppose a patient comes to you at 7 days or 10 days, which is a group of patients where you can think that you will require a lot of efforts, lot of workup, and probably the fever may not be identified in next 14 days. It could be people who are exposed to radiation or occupational exposure, patients having underlying infection like HIV or inflammatory disease, a strong family history or medical history of prior malignancies. The pyrexia of unknown origin would be very common. People consuming alcohol in excessive amount, low socioeconomic background, unvaccinated individuals, especially above the age of 65, those traveling to an endemic place where we'll have a couple of slides separately for them, recent contact with infected individuals, and exposure to animals. If you get any of these risk factors, be prepared to face a wonderful music before you reach a diagnosis. What is the diagnostic workup in a case of PO? Well, there are no set rules, but still you have to be methodical. Looks little paradoxical. No, there is no algorithm, no set rules, but still you have to be methodical. What is that? The answer is you cannot go for blanket investigation on day 5 or day 10. First, collect the history, including occupational and travel history. Once, twice, thrice. Talk a lot about previous illnesses, especially surgeries and psychiatric illnesses. Talk to the patient and relatives for their dietary habits, consumption of dairy products, alcohol, animal contacts, sexual history, and importantly, drug history. Because drug fever occupies 15% of cases of pyrexia of unknown origin. Practically all classes of drugs can cause fever. Commonest antimicrobial, especially beta-lactam antibiotics, which you have seen day in and day out. Post-operatively, patient is stable, no local site infection, still develops fever later on after 48 hours. You withdraw beta-lactam antibiotic and fever disappears. Nitrofurantoin, rifampicin, quinidine, antineoplastic drugs, and phenytoin and amitriptyline. These are the drugs that is common, those are commonly associated with drug-induced fever. A huge long list, but these are common one. And to me, the commonest one is nitrofurantoin, which is being used very frequently. Second one, nifedipine. Right? How do you diagnose drug fever? Generally, a drug fever begins 1 to 3 weeks after starting treatment. Nitrofurantoin is a drug which is being used for a prolonged period in UTI. The culture becomes negative and patient starts developing fever. Think about nitrofurantoin induced fever. It could Drug induced fever can lead to any febrile pattern. Eosinophilia need not always be there. It is there only in 20% of patients. And fever remits usually 2 to 3 days after withdrawing the offending drug. So, in case of a patient who is on a drug for more than 3 weeks and has started a new fever, think about drug fever. What are the points that we need to look for in examination? First and foremost would be thrombophlebitis. Another one, injection abscess. Look for the head, sinusitis, temporal arteries, could be temporal arteritis, fundi for choroid tuberculosis, Skin and nails would also give you clue by of endocarditis with the help of splinter hemorrhages or clubbing. Thyroid enlargement may point to thyroiditis, which is again another common cause of persistent fever in a female in a young age. Heart murmur may again take you to infective endocarditis. Rectal examination is a must, genital examination is a must, and lower limb tenderness may take you to DVT. Full examination of spine is a must. Review of dentition is equally important. Fundoscopy, I have already talked. Breast examination is something which has been ignored very frequently, and you miss a diagnosis. Pelvic and rectal examination, especially in a male, to look for prostatitis or to think about prostatitis. Any implant is a potential site of infection. So think about implant, especially prosthetic joint, even though the joint or material or any implant has been implanted more than 6 months back. Still, it can be a site of infection. It could be pacemaker, it could be a pacemaker wire, or it could be CVP line. One should always think about recent travels, exposure to pets that we already talked about. Look for skin, mucous membrane, and lymphatic system. What are the red flags? If a patient of POU has weight loss, start thinking about chronic diseases. Increased lethargy, think about sodium. Drenching night sweats, chronic diseases. Inability to perform activities of daily living, think about central nervous system. And changes in other symptomatology or physical examination. Everything is important. In immunocompetent individuals, the commonest cause is infective endocarditis. Even a culture negative endocarditis do exist. Same way, discitis, the inflammation of intervertebral disc, osteomyelitis, occult abscesses, and infected implanted devices. So start thinking about this. And as I told you, unless and until your mind is working, unless and until your mind is thinking about multiple diagnoses, you cannot diagnose pyrexia of unknown origin. Again, when you are thinking about suspected endocarditis and negative blood culture, think about abnormal organisms. It could be a group of fastidious hemophilus like organism, or it could be Coxiella burnetii, Q fever, or Bartonella, or Brucella. So once you are very sure that you have reached very close to endocarditis diagnosis and blood cultures are negative, again you have to start thinking in a broad way when it comes to investigation. And therefore, pyrexia of unknown origin is not only thinking in terms of history and examination, it is also in terms of thinking broadly about investigation. Resistance organisms are becoming very common these days, and a patient who has recently been hospitalized, by recent I mean last 6 months, one can always think about the nosocomial infection as a cause of pyrexia of unknown origin, especially as I told you, if the patient has taken lots of courses of antimicrobial, this is very likely. Returning travelers, returning from some other country, start thinking about the geography of that country and the diseases prevalent in that country. And for that, you require to ask about length of the travel time, accommodation, where did he stay, food, beverages, activities, use of bed nets, bites, sexual exposure. We have seen so many cases going to USA or going to Canada in the valleys or in cases of Rocky Mountain area and getting exposed to typical viruses. Sexual exposure, one need to ask in most of the cases, animal and freshwater contacts, and chemoprophylaxis and antimicrobials used. Diagnostic approach, how do you diagnose? Most important sentence is early blanket testing for all possible etiologies is inappropriate. Investigation should proceed through at least two stages of baseline test. So go for baseline test, repeat them after 3 or 4 days, only then start going for specific test. Because the more the tests are done, the likelihood of a wrong or misdirected physician would be there. So number of tests should be limited and step by step. If you go for 10 tests at a time, 4 of them would be showing different results and you will be misled. So how do you go ahead? After taking complete history and physical examination, if there are positive findings, give appropriate diagnostic testing orders. Otherwise, go for basic investigation. No positive results, start thinking about radio imaging one by one. Try to classify the PUO into four different categories: infection, malignancies, autoimmune, and miscellaneous. If it is infection, think about AFB, urine or sputum culture, VDRL, or serology, or even PCR. If it is hematology, find out a very good pathologist and ask him to go for peripheral smear, because peripheral smear gives you the best possible identification of hematological malignancy, followed by protein electrophoresis. Non-hematological, you may require multiple investigation. Autoimmune, very limited investigation, but think about temporal artery biopsy or even a skin biopsy if there's a lesion. And then miscellaneous, you may require a lot of things. Other diagnostic workup include thyroid function test, ACE levels, especially when you are thinking about sarcoid, venous Doppler, WBC scan, or barium studies. These are few investigations which may be thought about. What is the change in last 5 years? The use of positron electronic tomography, that is PET CT, has led to the development of reasonably easy access to about 20% of cases of pyrexia of unknown origin, which were difficult to diagnose. And the new molecular and serological test, even the development in anti-nuclear antibodies and also the PCR test have helped us to diagnose pyrexia of unknown origin up to about 50% of cases. As I told you, the cohort of undiagnosed patients have generally a good prognosis. So don't be very proactive unless your patient is having some hemodynamic changes or the pyrexial range is very, very high. As we'll see in a next case. Each test should only be performed when there is a reasonable pre-test probability, and each test must be interpreted in view of its positive and negative predictability, which means whether it is the sensitive and specificity of a test. Like RA titer, rheumatoid arthritis titer, alone may not be very specific, but when interpreted with the help of anti-CCP antibodies, it becomes specific and sensitive. So, whenever you are encountering pyrexia of unknown origin, think about specificity and sensitivity of a test. So now we go to the last part of the story, and that's a very wonderful case given to us by our infectious disease specialist, Dr. Aniket. 18-year-old boy, known case of thalassemia major, receiving PCV transfusion every 21 days on oral iron chelation therapy. No major past medical history apart from being thalassemia major. Presented with these complaints for last 45 days. Believe us, it was 45 days. Fever, right hypochondrial pain, back pain, and weight loss. 6 kgs. You started thinking immediately just 4 things, and our mind goes on thinking fever, right hypochondrial pain, liver has been involved, back pain, spine has been involved, weight loss, tuberculosis. We have reached a diagnosis. Well, that's not the way to diagnose pyrexia of unknown origin for 45 days, because most of our colleagues would have thought about this and would have done it. Patient had developed fever which was high grade, spikes up to 107-degree fever, generally 2 to 3 spikes of 103 to 104 with chills and rigors. Mild headache, body ache, no night sweats, no diurnal variation. Right hypochondrial pain which was stabbing in character, aggravated by coughing and deep breathing, moderately severe in intensity, radiating to back, no diurnal variation, no relation with meals, no alteration in bowel habits. Did you notice one thing? Everything, whether it was fever or right hypochondrial pain, has been thoroughly explored, fully asked about everything that one can about ask about characteristics. The boy had back pain, which was on either side of the spine in the lower back, continuous boring pain, increase on sneezing, coughing, deep breathing, associated with difficulty in walking with straight back, relieved by lying supine and non-radiating. Again, every possible characteristics of back pain. So, physical examination, hemodynamically stable, air entry reduced on right lower zone, CVS tachycardia, liver palpable, spleen palpable, tenderness present over right hypochondrium, gibbous present, tenderness present along paraspinal region at lower dorsal vertebral level. Reports, basic reports, as I told you, first 3 and 7 day baseline report twice is a must. 8700 count. There is lymphopenia, HB anemia, platelets are normal, CRP is raised, ESR is raised, SGPT, SGOT raised. Normal sugar renal function, prothrombin time is okay, INR 1.6 little prolonged, lipase, alkaline phosphatase, bilirubin normal, culture blood negative, normal urine routine micro. Of course, sonography has been done, shows hepatomegaly, multiple tiny hypoechoic areas with central tiny echogenic spots. Could be infiltration, could be abscess, could be metastasis. Moderate splenomegaly 12 centimeter. No ascites, no lymphadenopathy. So it's not portal hypertension. Received a course of antibiotics, azithromycin and cephalosporin for 7 days. Sonography was done again, practically the same with the same picture. That is, pyrexia persists, right hypochondrial pain persists, and back pain is there. CT now shows multiple necrotic modular infiltrates. Largest lesion appears to have ruptured with focal perihepatic anterior subcapsular collection. Multiple enlarged nodes at porta hepatis, upper abdomen, pre-paraortic, paracaval regions measuring around 8 to 12 millimeter with perinodal infiltration and necrosis. X-ray dorsal lumbar spine is there, MRI spine is there, which shows altered signal intensity of marrow involving D10 vertebral body. So all in all, it fits into tuberculosis, right? This is MRI spine. So we have got a 18-year-old male, thalassemia major, 6 weeks of high-grade fever, chills, rigors, multiple liver abscess, paraspinal collection, multiple enlarged abdominal nodes with periadenitis. AKT obviously started, but keeping 6 diagnoses in mind. Suppurative infective condition, high-grade fever, swinging temperature, rigors, chills, lymphopenia. So, suppurative infective condition could be bacterial, Staph aureus or E. coli, Mycobacterium tuberculosis, non-tuberculous, Brucella, nocardia, and fungal. AKT was started, no response after 15 days. CT guided aspiration was done, sent for culture. Meanwhile, we started thinking in this way: which infections are common at his age, 18 year? Which infections are common with his geographical location? Which infections are common which can cause such picture? And then we suddenly realize he's having thalassemia major. We opened up books and asked which infections are common in thalassemia major in his age group. And we got the answer before we got the culture sensitivity. Answer was disseminated melioidosis. The pus grew Burkholderia pseudomeli in 2 different laboratories, and we could reach the diagnosis. But we realized that thalassemia major patients have 7% chances of disseminated melioidosis even before you get the culture. So easy to treat. Ceftazidime, 1.5 gram IV 6 hourly, supportive care, coughing because of right pleuritic pain. Spine surgeon suggested to be conservative. 30 cc of paraspinal collection was withdrawn. Was seen only after 1 week of antibiotics, which was sterile. No organism grew. Fever spikes went down, and patient was discharged in stable hemodynamic condition. 40 days of same injections, and patient was out. However, the melioidosis requires a long-term treatment with cotrimoxazole for 3 to 6 months. So, conclusion: when investigating a patient with pyrexia of unknown origin, consider possible etiologies in each of the following four blood categories: infective, inflammatory, neoplastic, and miscellaneous, and also immunocompromised. Address each in turn. Pyrexia of unknown origin is a diagnostic challenge, and early involvement of specialists or a team of specialists is important. The balance of cause of pyrexia of unknown origin varies over time and across different populations. Investigation should be undertaken based on the most likely cause or causes. Again, emphasizing blanket investigations are not recommended, as positive or equivocal tests are difficult to interpret in the absence of a suggestive exposure history or clinical syndrome. This can be misleading and potentially cause harm to the patient. Empirical therapeutic trials are not recommended before a diagnosis is made. The overall outcome of a patient with PO is good, especially when no cause is found. So, PO remains a clinical challenge despite greater understanding of diseases responsible and increased access to the diagnostic test. That's where we'll stop.
Thank you so much, sir, for that enlightening and thought-provoking session, sir. We will now take a questions from audience. I request all participants to drop their queries in the chat and I will read them out for sir. So the first question is, how do we integrate autoimmune diseases in the FUO workup?
Well, unfortunately, these days, physicians have become, I would say, overactive, and therefore, in a case of pyrexia which persists for 7 days, we start exploring practically all possible autoimmune diseases, and so by the time it reaches the timeline of 3 weeks, most of the autoimmune disorders have been explored about. But the important points would be temporal arthritis, still one could think about as an inflammatory disease. The inflammatory bowel disease, which fall under inflammation and autoimmune both, are also something that is frequently being missed. But still, I would suggest anti-nuclear antibodies as one of the screening tests in this group of patients. Another important thing that is generally missed is autoimmune thyroiditis in a young female, where one should go for antibodies. Recently, we had a case of Graves' thyroiditis who came to us with a blood sugar of 342, a young female, and we investigated for uh, get antibodies. It was negative. Then, rather than thinking that this is not a type 1 diabetes, we thought about autoimmunity again, and we sent all possible antibodies for type 1 autoimmune diabetes, and it turned out to be positive. So it was a case of multiple autoimmunity, and therefore, if a patient has at least one autoimmune disease, give a lot of effort or emphasis on working up for autoimmunity.
Okay, thank you so much for the answer, sir. I hope you did justice with the answer, sir. So the next question we are, what are the subtle clinical clues pointing towards vasculitis or connective tissue disorder?
Right. Very limited things are there because they can present by any feature. And that's why they generally go into the armamentarium of pyrexia of unknown origin. But the common features, let's start from the history. So, involvement of multi-system, first of all. Involvement of the skin, number two. Skin with some other system. Involvement of GI and joint. These are multi-system involvement would always lead you to suggest that it is probably an autoimmune disease. Look at the physical examination. Like many a times, you forget to look at the face of the patient and you may miss the classical SLE features of the patient on the face, where there's a discoloration of the face in a very typical pattern. Temporal artery pain, temporal arteritis may be missed. Same way, forgetting to look for urine protein or forgetting to look for urine routine microexamination may mislead you to some other thing. So these are few points which can suggest that there is a possibility of autoimmune disease. But again, I will like to draw your attention. If there is one autoimmune disease present, always think about it. And the commonest one would be skin presentation, pulmonary presentation, and joint presentation.
Okay, thank you so much for the answer, sir. And the next question we received, sir, how can genetic and auto-inflammatory syndromes be better identified in FUO cases?
Very difficult. And probably, I believe that those 15% of cases which are undiagnosed would be falling under some genetic causes which are at present very difficult to diagnose. But when it comes to inflammatory, yes, we have got now lots of modalities which are available, starting from the lower GI scopy, which can diagnose an ulcerative colitis or Crohn's. We generally feel that Crohn's is not a disease to diagnose in Indian setup, but we have started seeing lots of cases of Crohn's here. We can go for serology, we can go for blood investigation, we can go for fecal markers when it comes to GI inflammatory diseases. Same way for thyroid, we have got now better antibody titers which are available and which can help you to diagnose. A simple look at CRP, which is going on, increasingly on, would suggest you there is some inflammation in the body. So inflammatory disorders could be inflammatory joint, like gout or like rheumatoid arthritis, are now reasonably easy to diagnose. But again, specificity and sensitivity of a test is a must. Ultimately, it is a PET scan which always helps to diagnose malignancies which may present as inflammatory disease.
Okay, thank you so much for the answer, sir. So the next question we received is how long should we observe before labeling a case as FUO?
Well, it has been very clearly defined, as I told you. 3 weeks of pyrexia, more than 102 degree Fahrenheit in most of the days during those 3 weeks, where during which time there are at least three OPD visits, and there is, if no three OPD visits are there, at least 3 to 5 days of hospitalization has not revealed the diagnosis. That is what PUO is. So in most of the cases, by this time, we have been able to diagnose or we have been able to suspect. But only after 3 weeks of 102 fever persisting on most of the days during these 3 weeks, and the investigations, whatever have been done, has have not yielded any diagnosis. That is understood as a PO.
Okay, thank you so much for the answer, sir. Sir, as I can see, only one question is left. So the question is, what is the best stepwise approach FUO in a resource limited setting?
The stepwise approach starts from the history. As I told you, most of the time you find out history gives you some clue which rest of the people or rest of our colleagues might have missed. So when a patient of PUO comes to us, or for that matter pyrexia of a longer duration, who has already been explored and has not reached a diagnosis, find out some time, 30 minutes, 40 minutes, to look for the history. Ask anything, everything that is possible. Where did he move in last 6 months? Any hospitalization, antibiotics, travel history, exposure to occupation, exposure to the pets, exposure to water. Start everything about it. Then look at the investigations which have already been done. Many a times it may also clinch a diagnosis. Like one of our patients had high eosinophil count, for which he was always treated with levocetirizine, but somebody had missed a diagnosis of eosinophilic granuloma. So look for all the investigations that have been done. So give enough time. Each paper of investigation may give you some clue. So just give enough time to look for the history and investigations, And only once that has been done, divide your patient into four groups. Whether he falls more in the inflammation, whether he falls more in the common one, that is infective, whether he falls in the autoimmune category, or whether he falls into immuno compromised state or neutropenic state. And accordingly, go ahead further for the investigations.
Thank you so much, sir. I hope you did justice with all the answers, sir. And we look forward to having more such sessions with you in the future, also, sir. And on behalf of Med Talks and IGCP, I sincerely thanks Dr. Urman Truf for his valuable time and expertise today. And thank you to all the attendees for joining us. And stay tuned for more such engaging Med Talks digital sessions with leading experts in healthcare, sir. With all your permission, I'm going to conclude this session, sir.
Thank you, Ada, and thanks, Metro. Thank you very
Thank
much.
you so much, sir.